Hi, I'm Megan. I'm a PhD student at the University of Sheffield, and this is presenting some early work from my PhD about simultaneous employment and health trajectories following a period of economic inactivity due to long-term sickness. So this is where people are economically inactive, so are not in work and not searching for work, and their primary reason for given so is long-term sickness, which is very related to this topic of health, well-being and labour market non-participation, which is the theme of today's Symposium. So as a bit of background, economic inactivity due to long-term sickness, or I'll refer to it as long-term sickness throughout, has been increasing since around the start of 2019 in the UK, and then continued to increase throughout the pandemic. And there are now about 2.8 million people in the working age population, so those aged 16 to 64 years old, who are inactive due to long-term sickness. And this increase has triggered a bit of a worry about this idea of a working age health crisis in the UK and concerns that this will impact upon economic growth, which is at the heart of government policy currently. And you can see this in things like the Get Britain Working paper that came out in November. And one of the key things is that a lot of these people are quite young, like nearly a quarter under 35. And if we're assuming that people have long periods of time in the working age population from 16 to 64, those under 35 have a long time in which we are considering them as part of the labour market who could be participating. And a big thing is that a lot of people who are long-term sick become long-term sick for a very long period of time, with only 3% moving into work at any given year. So this is something that I wanted to explore a bit further and think about the outcomes for people who experience a period of long-term sickness. So the kind of aims of this work were to think about the fact that economic inactivity due to long-term sickness isn't a fixed state. It isn't an all-encompassing, absorbing state that you can never leave. It's a state in which most people are transitioning into due to the onset of some form of work-limiting illness or health condition, though that isn't the case for everyone, and it should be noted that we should not expect everyone to work. There are plenty of people who are disabled in some way and are not expected to participate in the labour market, and this is why we have social support systems in place for those people. But for a lot of people, it is a point in which their labour market participation and their health status are really coming together, and both are unifying to create this status of being economically inactive due to long-term sickness. And then when we want to think about the outcomes and the futures of those people, we really should be thinking about that in terms of both their labour market participation or their future economic activity and their future health status, and how those two play together, rather than focusing just on their health or just on their economic activity, given that this period has been shaped by both their health and their work. So the kind of aim of this work was to look at the short to medium term, so 1 to 5 year employment and health outcomes for individuals who transition or experience the onset of a period of economic inactivity due to long-term sickness. So we've seen about 8.8 million people join the state in the last 5 years. And what's sort of happening to those people who are adding to that estimate that we've seen creeping up over time? So for this, I wanted to use a longitudinal population study, such as the studies included by Closer. And I wanted to use a study in which we could identify those onsets of long-term sickness. So seeing people prior to their economic inactivity and then have them followed up for a long period of time in terms of both their economic activity and their health. And the obvious solution for me was to use the UK HLS, an annual household panel study, which I'm sure lots of people are aware of. So my sample was derived from waves 1 to 14 of the UK HLS, focusing just on people in the working age population who experienced the onset of long-term sickness from any other economic status prior to that. And this ended up with a complete case analysis of around 1,000 participants. So not lots, considering that the UK HLS has 20,000 households within it. And for those who are a little bit more interested or have more knowledge of the UK HLS, this sample is derived from people transitioning into this orange status, so into a period of long-term sickness, and then the 5 years of follow-up. So this is actually including people who transition into long-term sickness up until about 2020. So it doesn't include anyone largely with long COVID, and it's a sort of flaw of the methodology in some ways is that we can't follow people into the future, which is the standard of using longitudinal data. So in terms of like thinking about their measures of work and health and how we want to look at those together, in terms of work or economic activity, this is considering employment, especially making a distinction between full-time and part-time employment, but importantly, making a distinction between different types of economic inactivity. A lot of the time it's grouped together and people are just economically inactive without a distinction between people being students or being retired, which are often seen as positive things, versus people who are on long-term sickness, which is usually implied to be a negative thing for their labour market participation. And then in terms of health, which is going to be looked at alongside the economic activity, this is using self-rated general health, which is a very common subjective health measure. It's also what we base things like healthy life expectancy off. So it does have some flaws in which it's not focused on mental health and it's a much more general measure, but it allows for the methodology I'm using, which is a sequence analysis approach. And you'll be able to see this in the following slides. So using a sequence analysis approach considers people to be in exclusive sequences over time. So here you can see that in terms of economic activity, all individuals begin in long-term sickness. So they all transition into a period of long-term sickness. But some individuals then transition into full-time employment in subsequent years, while some remain in long-term sickness for the whole period, and others have a more diverse range of economic activities throughout the follow-up period. And here it's year 0 is their first year of long-term sickness, and it's followed through for 5 years, but it's labelled as 0 to 4. And then you see the same with self-rated health. So at the beginning, these are all the people who are currently in long-term sickness, and they're usually in poor or fair health in this example. And then some people improve in terms of their health, whilst others remain in poor health throughout. And in a usual sequence analysis, you're just focusing on either economic activity or self-rated health and considering the trajectories of people in terms of those measures. But a multi-channel sequence analysis considers both of these together. So it's considering both economic activity and self-rated health together for each of the participants and how these might move and change over time in a more joint fashion than if you looked at them separately. So it's thinking about this dynamic of work and health and well-being and labour market participation together in this multi-channel way. So to do so, we're thinking about the sequences as being different in terms of their states. So are you employed? Are you economically inactive due to long-term sickness? How long for? At what point? And how those differ. And each individual has their own sequence, as you've seen before. But we use something called optimal matching to transform the sequences to look like one another through edits. So these are things like insertions or deletions of states, so removing periods or substituting periods for other states. And all of these can be used to calculate a level of dissimilarity between the sequences. And you use this level of dissimilarity to cluster them together. But in doing so, you cluster channels in a multi-channel sequence analysis whilst considering both the differences in work and health together. And this is using hierarchical clustering. So we're going from many clusters in which each individual is their own cluster. So we've got 952 participants and each individual was originally their own cluster. And then this is slowly grouped together into fewer and fewer clusters. And I've ended up with 5 clusters based on a number of cluster diagnostic statistics, such as average silhouette width. And these are grouping together people with similar work and health sequences to try and derive some typologies of the experiences of employment and health for people who experience the onset or transition into a period of economic inactivity due to long-term sickness. So these 5 clusters look like this, and I'm hoping that everyone can see this reasonably well. So this 5 cluster solution is kind of using different descriptions of the clusters to think about what the different typologies are. So all individuals are experiencing at the start the onset of a period of long-term sickness. And you can see for some individuals that remains throughout, such as cluster 4. People are in long-term sickness, so economic activity is measured at the top of these clusters and self-rated health at the bottom of these clusters. And in cluster 4, people are in long-term sickness and they're in quite poor health throughout. And then you see things like cluster 1, which I'm termed as a trigger for retirement, in which people are in their period of long-time sickness, and then that triggers them to largely move into retirement with kind of quite a stable pattern of health throughout, a mix of poor and fair health. Whilst something like cluster 5, people then return to employment very quickly, return to this teal colour, and their health is improving. You're seeing more of those green colours. Cluster 2 and 3, I've described as precarious. You can see that there's a mix of long-term sickness, of unemployment, sort of blue colour, of part-time employment, sort of brown colour, and sort of also caring responsibilities. But the main difference is that there's a difference in the levels of health between clusters 2 and 3. So cluster 2 is largely this yellow colour in terms of health. It's yellow and green. People are in quite good health, but they're still struggling to return to a sort of full-time employment or to be fully participating in the labour market. Whilst cluster 3, people are much more in fair health or more poor health, and this might show why there's slightly more dominance of long-term sickness within this group. But for the rest of the talk, I thought I could focus on just clusters 2 and 5 because they have quite similar health profiles. There's a similar pattern of health, but they have quite different economic activity profiles. So if I just focus on cluster 2, this precarity and good health, and cluster 5, this sort of return to employment, as I've said before, they're in a sort of similar level of health, fair or good, but cluster 2 is much more characterised by unemployment, part-time work or caring responsibilities and continued long-term sickness, whilst cluster 5 sees a much clearer return to employment within 1 or predominantly within 2 years. So to consider some of this, I've done some early descriptive statistics of the characteristics of individuals in these clusters prior to their transition into a period of long-term sickness. And what you see is that whilst the age is quite similar, which surprised me somewhat, I thought that cluster 2 might be younger and more precarious. And the gender balance is quite similar between like the proportion of men and women. There was some hypotheses that there might be more men in cluster 2. The main thing is that in cluster 2, a lot of people were not in employment prior to their period of long-term sickness. They were struggling, or they were either unemployed or economically inactive prior to their period of long-term sickness, though that reason wasn't given as long-term sickness itself. Whilst for cluster 5, the majority of people were in employment, so it makes sense that they are willing and keen to return to employment quickly following a period of illness. And this is the key distinction I've tried to untangle when looking at these clusters, where the health profile would expect you to have similar outcomes, but we need to consider that it is just health and employment together to think about people's outcomes. In terms of some future methodological developments, 952 participants is not that many people, and I'm looking at some imputation approaches to consider how to fill in the gaps of some people in the longitudinal data who, in understanding society, people are permitted to leave the study and return, so have gaps in their follow-up with a 5-year follow-up period. I'm looking at doing a multinomial logistic regression approach to kind of develop those descriptive statistics further and think about the characteristics that make individuals more likely to be in each of these clusters. So who is more likely to experience a quick return to work following a period of long-term illness versus those who really struggle to engage with the labour market following a period of economic inactivity due to long-term sickness. There's also, for people who are more interested in the methodology, a lot more sensitivity analyses that could be conducted with this kind of sequence analysis methodology in terms of some of the dissimilarity measures and the algorithms used for clustering. But I think a key further methodological piece of work is to do a subgroup analysis focusing just on those who are in employment prior to their period of long-term sickness. So those who were in work and then for whatever reason have experienced an event in which they transition out of work into a period of economic inactivity, and then thinking about their outcomes separately to those who were already struggling with the engagement in the labour market prior to a period of long-term sickness. And I think this kind of subgroup analysis feeds into thinking about the sort of implications and like future options for this kind of research. in which a lot of the work is focused on the prevention of the onset of economic inactivity, so due to long-term sickness. So thinking about interventions that can prevent this from happening in the first place, rather than considering outcomes for those who are experiencing this, because there are millions of people in the country who have this as their lives, and they are experiencing a time period of work in which they are off work due to long-term illness, and they're not looking for work, and they're not in work at the time. So this is trying to identify a number of different trajectories for their future health and employment following the onset of a period of economic inactivity due to long-term sickness, and help us to think about sort of return to work interventions in terms of who we should be targeting and what type of support we should be targeting towards people. And that those who return to work very quickly were usually in work prior to their period of long-term sickness and seem to be able to return to work quite quickly, and perhaps need less support than those who were already struggling with engagement in the labour market and perhaps need more targeted and specific support to be able to enter or return to the labour market. And you can see this, and I hope Bruce discusses this further, in terms of the policy agenda for the UK government, in which we have the white paper in November of Get Britain Working, the Pathways to Work green paper, which really calls for a more integrated health and employment support system, specifically targeting people who are out of work due to long-term illness. And then you get the Sir Charlie Mayfield Keep Britain Working review from March, and it's ongoing currently, which is considering approaches in different countries and thinking about what we can take in the UK to support people from systems elsewhere. Thank you very much, and feel free to ask any questions.